Welcome to the deep dive. Today we're really getting into something important, managing chronic coronary syndrome, or CCS.
That's right. It's that long-term side of ischemic heart disease where the heart's blood flow isn't quite keeping up.
Exactly. And it's a major issue, a leading cause of, well, morbidity and mortality.
Yeah.
We're basing our discussion today on the ACE clinical guidance.
Which is fantastic because it's evidence-based but really contextualized for us here in Singapore, especially for primary care.
Definitely. It gives us practical recommendations. So, to make this real, we thought, let's do a bit of a role play.
Good idea. Like an initial consult.
Yeah, picture a typical scene. A 65-year-old woman, let's call her Mrs. Tan Mai Ling, comes into the clinic. She's got this predictable chest discomfort when she exerts herself.
Okay, let's set the scene. Mrs. Tan is seeing a family medicine resident.
Right. So Mrs. Tan starts.
Doctor, I'm here because I keep getting this chest discomfort when I walk up the stairs. It started maybe 6 months ago, and it goes away when I rest, but I'm really worried it's something serious, with my heart.
Okay, Mrs. Tan, thanks for coming in. Tell me more about this discomfort. Where exactly do you feel it?
It's right in the center here. It feels sort of heavy, like a squeezing feeling.
Heavy squeezing in the center. Okay. And what brings it on? You mentioned stairs?
Yes, usually climbing the 2 flights to my flat, or sometimes if I walk quickly uphill, usually starts after a minute or two.
Okay. And how bad is it, say, on a scale of 1 to 10, where 10 is the worst?
Oh, maybe a 5. It's noticeable, definitely. Moderate, I suppose.
A 5 out of 10. And what makes it feel better?
Just stopping. If I stop and rest, it goes away. Usually quite quickly, maybe 3 to 5 minutes.
Okay, rest helps within minutes.
Yeah.
Does the feeling travel anywhere, like down your arm or to your neck or jaw?
No. It just stays right there in my chest.
Right. Any other symptoms with the discomfort? Feeling breathless, sweaty, dizzy, sick to your stomach, or like your heart is racing?
Not really with the pain itself.
Yeah.
I might get a bit breathless, just before it starts when I'm climbing. But I thought that was just exertion. No sweating or dizziness during the actual discomfort.
Okay. And does this ever happen when you're just resting? Or maybe lying down, sleeping?
Oh, no, never. Only when I'm active, like the stairs.
All right. Has anyone ever given you a medication, like a spray or tablet to put under your tongue for this? Something called GTN, or glycerol trinitrate.
No, doctor. Never had anything like that.
Okay. Can you tell me about your other medical history? Any conditions you're treated for?
Yes, I have high blood pressure. Had that for about 10 years now. And type 2 diabetes, maybe 15 years. Also high cholesterol for several years.
Okay. Hypertension, diabetes, high cholesterol. Have you ever had a heart attack before? Or any heart surgery? Or a stroke?
No, thank goodness.
That's
None of those.
good. And what medications are you taking for these conditions?
Let's see. Metformin, the big tablet, 1 gram twice a day. Lisinopril, 10 milligrams just in the morning. Torvastatin, 20 milligrams at night. And I take a small aspirin every morning. I think it's 100 milligrams. Is that right?
Okay, thanks. And how are you doing with taking them all regularly? It can be tricky sometimes.
I try my best, doctor. But sometimes I do forget. Maybe a dose here or there, once or twice a week perhaps, for some of them.
Okay, thanks for being honest. Any allergies to medications you know of?
No, none I know of.
And what about your family? Any history of heart problems or stroke?
Ah, yes. My father, he had a heart attack. He was quite young, early 60s, I think. And my mother, she had a stroke.
Okay. And what do you do, Mrs. Tan? Are you working?
No, I'm retired now. I used to teach primary school. I live with my husband in an HDB flat. So, yes, those 2 flights of stairs.
Right. Do you smoke or drink alcohol?
Oh, no, never smoked. Don't drink either. I used to enjoy walks, but lately I've cut back. I'm just afraid of getting that chest pain again.
I understand. What about your diet generally?
I try to eat healthy, mostly cook at home, but, sometimes hawker food.
Okay. When was your last checkup? Any recent tests?
6 months ago, I think.
Hmm.
The doctor said my BP and cholesterol were,
Okay.
but could be better. I had an ECG then, too. They said it was normal.
Do you remember any blood test results? Maybe for sugar or cholesterol?
Yes, they did blood tests. My sugar, the HbA1c, was 7.5%, and cholesterol, the bad one, LDL, was 2.8. No other heart tests, though.
Okay. What are your own thoughts about what might be causing this discomfort?
Honestly, doctor, I think it's definitely my heart.
And what worries you the most about this?
I'm just so scared of having a heart attack like my father did. And I worry, is my current medicine not working well enough? Will I need an operation? Can I, live normally? be active without this fear hanging over me.
Those are very understandable concerns. And what are you hoping we can achieve today?
I really want to understand what's going on and, well, find some treatment, something to stop the pain, protect my heart, so I can go for my walks again without being afraid.
Thank you for sharing all that, Mrs. Tan. It's very helpful. Now, I'd just like to do a quick physical check. If you could lie down on the couch for me.
Okay, let's pause the role play there.
Yeah, that was a great illustration. You can really hear the classic features coming out in Mrs. Tan's story.
Absolutely. That history-taking part is just so critical. The
Yeah.
resident really drilled down into the specifics. The heavy, squeezing nature brought on by exertion, relieved quickly by rest. Textbook stable angina presentation.
Textbook. And for our residents listening, really focusing on that PQRST framework, precipitating factors, quality, radiation, severity, timing it helps structure your thinking and ensures you don't miss key details. Mrs. Tan's story fits it perfectly.
Right. And notice how the resident didn't just focus on the chest pain, but also asked about those crucial cardiovascular risk factors.
Essential. The hypertension, the diabetes with an HbA1c of 7.5%, the dyslipidemia, the ACE guidelines really hammer home the need to get these under optimal control. That 7.5% suggests her diabetes management could probably be tightened up, for instance.
And the family history adds another layer of risk. Father with an MI in his 60s.
Yep. All pieces of the puzzle.
Okay, let's quickly jump back to the resident, finishing the examination and explaining the plan.
Okay, Mrs. Tan, you can sit up now. Everything seems stable right now. Your blood pressure is 132/80. Heart rate is 72, nice and regular. Breathing's fine, temperature normal, oxygen level is good.
Okay.
Listening to your heart, the sounds are normal, no murmurs. Your pulses feel strong and equal, no swelling in your legs. And your lungs sound clear.
So what does it mean?
Well, based on everything you've told me, the pattern of your discomfort, your history, and my examination, it seems most likely that you have something called chronic coronary syndrome. Often we call this stable angina.
Oh, dear. Angina. That sounds serious.
It's definitely something we need to manage carefully. But stable is the key word here. It means the discomfort is predictable, comes on with a certain amount of exertion, goes away with rest, and the pattern hasn't really changed much over the last 6 months. That's reassuring in a way. Importantly, you're not having pain at rest. The pain isn't suddenly getting worse or happening with less effort, and you don't have those other severe symptoms like sweating during the episodes. These are things we look for to rule out unstable angina or something more acute.
That's a really important distinction the resident made there. Stable versus unstable.
Critical. Reassuring the patient while also explaining the diagnosis clearly and highlighting why it doesn't seem like an immediate emergency right now based on the lack of red flags.
So the next steps in the clinic would involve some investigations.
Yes. So we should do some tests to confirm things and check on your overall status. You had a resting ECG 6 months ago, which was normal. That's good, but we'll repeat one today just to be sure. We have your recent blood tests for lipids and HbA1c, which is helpful. I'll also order a couple more blood tests, a renal panel to check your kidney function, and a full blood count, just standard checks.
Right, those baseline investigations we often do in primary care. ECG, lipids, HbA1c, renal function, FBC. Gives a good starting picture.
Exactly. The ECG might show signs of old damage or strain, though a normal resting ECG doesn't rule out CCS, as in Mrs. Tan's case. And the bloods help assess risk factors and check for other potential contributors like anemia.
Now let's talk about lifestyle. It's great you don't smoke. Diet-wise, continuing to focus on healthy eating is important. For exercise, I know you've been hesitant, but regular activity is actually very good for your heart, Mrs. Tan.
But the pain.
I understand. The key is to find the right level. We'd suggest starting with low-intensity activities, maybe walking on the flat and gradually increasing, but always stopping before the pain starts. We don't want you to push through the discomfort. Down the line, we might even discuss cardiac rehabilitation, a supervised exercise program. Maintaining a healthy weight is also beneficial.
That exercise advice is key, but needs careful tailoring. The guidelines do mention contraindications, like if the angina was unstable or if there were severe symptoms. But for stable patients like Mrs. Tan, finding that threshold and gradually building up, maybe with cardiac rehab, is the way to go.
And medications, that's a big part of management.
Yes. We need to look at your current medications. Firstly, it's really important to try and take them as regularly as possible. We might need to adjust the doses slightly to get your blood pressure and blood sugar even better controlled. And then we need to think about medication specifically for the angina. Often the first thing we try is a beta blocker. This medication helps slow your heart rate a bit and reduces how hard it has to work, which can prevent the pain from starting. We should also prescribe you a short-acting nitrate. This usually comes as a spray or a small tablet you put under your tongue if you get the chest pain. It works quickly to widen the blood vessels and relieve the discomfort. That's the GTN I mentioned earlier.
Okay, so one to prevent it and one to use if it happens.
Exactly.
Good explanation there. Beta blockers as first-line anti-anginals is a key takeaway from the guidelines for our residents. Reduces myocardial oxygen demand.
Right. And if beta blockers aren't tolerated or aren't enough, then calcium channel blockers are often the next step or can be added on. And that GTN for breakthrough pain is absolutely essential for patient confidence and symptom relief.
We also need to think about preventing clots. Mrs. Tan mentioned she takes aspirin.
Yes, low-dose aspirin is usually the cornerstone for secondary prevention, reducing the risk of heart attack and stroke. If someone can't take aspirin, maybe due to allergy or bleeding risk, then clopidogrel is the typical alternative. Mrs. Tan thought she was on 100 milligrams, but the standard low dose is often 81 milligram or 100 milligrams depending on formulation, so clarifying that would be good too.
And finally, Mrs. Tan, it's really crucial, when to get help urgently. If you ever get chest pain while resting, or if the pain feels much worse than usual, or if it lasts longer than, say, 10 or 15 minutes despite resting, or if you get very breathless or sweaty with it, you must call 995 for an ambulance immediately, or go straight to the A&E. Don't wait.
Okay, doctor, that sounds a bit scary, but I understand. It's important to know.
It is. But we will work together to manage this. We'll schedule a follow-up soon to check your test results, see how you're feeling, and adjust the plan if needed. Our main goal is to control your symptoms, reduce your risk of future problems, and help you feel confident being active again.
And that wraps up the initial consult phase, a really well-handled interaction by the resident. Covered history, risk factors, initial plan, medication discussion, and crucially, safety netting.
Definitely. Address the patient's concerns, too. You saw Mrs. Tan felt heard, which is so important. For our residents, that patient-centered approach alongside the clinical decision-making is key.
So, pulling out some key clinical pearls from this whole discussion and the ACE guidelines. Number one has to be that thorough history, really nailing down the angina characteristics.
Absolutely. Differentiating stable from unstable based on those features: exertional, relief by rest, stable pattern versus rest pain or worsening pattern. That's job number one in primary care.
Then comprehensive cardiovascular risk factor assessment and optimization. Not just identifying them, but actively managing the hypertension, diabetes, lipids.
Couldn't agree more. Getting that HbA1c down, the LDL cholesterol to target, the blood pressure controlled, it makes a huge difference long term.
And the medications. Antiplatelet therapy, usually aspirin or clopidogrel if needed.
Check. Anti-anginal therapy, starting with beta blockers usually, maybe adding calcium channel blockers, and always ensuring they have short-acting nitrates like GTN for immediate relief.
Plus, the vital role of lifestyle changes. We touched on diet and exercise, but smoking cessation for smokers is paramount. Weight management, too.
Non-negotiables. Lifestyle is medicine here, too.
And knowing when you need backup. While we manage a lot of CCS in primary care, if symptoms are refractory, if the diagnosis is uncertain after initial tests, or if revascularization might be on the cards.
That's when collaborative care with cardiology comes in. Further functional testing, maybe angiography, knowing those referral triggers is important.
So for all you residents listening, managing CCS effectively in your clinic involves putting all these pieces together: the careful history, risk factor management, appropriate meds, lifestyle counseling, patient education, and clear safety netting.
And regular follow-up. This isn't a one-off visit. It's about building a relationship, monitoring progress, adjusting treatment, and supporting the patient long-term. Use resources like the ACE guidelines that really are designed to help you with this.
Absolutely. So maybe a final thought for everyone listening to mull over. Beyond the medications and tests, how can we truly empower our patients, like Mrs. Tan, to become active partners in managing their CCS and embrace those lifestyle changes that are so crucial for improving not just their lifespan, but their quality of life?
That's the million-dollar question, isn't it? Something for us all to keep working on.
Indeed. Thanks for diving deep with us today on chronic coronary syndrome.